introduce you so that we can go ahead and kick this off. I'll put your bio in the chat in case anyone joins and misses it, but we're so excited to have Dr. Willy Lescano here today, joining us from Lima, Peru. Willy is an epidemiologist. He received his PhD in global epidemiology and disease control, as well as a master's in biostats and health policy from Johns Hopkins. And he's an associate professor at UPCH in Lima, and he also holds multiple joint appointments at Tulane, Hopkins, and Wake Forest and Texas Medical Branch universities. So you can see his full bio in the chat. He has an absolutely amazing resume. Between 2017 and 2018, he was the Director General of Peru's National Center for Epidemiology, Disease Control and Prevention with the CDC Peru. He is very well published, and he's also an amazing mentor who's mentored DGSOM students in the past. So we're really thrilled to have you here, Willy, and we'll hand it over to you. Vegeta can share your slides.
Thank you very much. I really appreciate the opportunity to talk to you all. It's been a really challenging year in many areas, has been for so many others. And what I wanted to share is a little bit of our experience working with the government, Peruvian government, in the response to COVID-19 pandemic in Peru as an epidemiologist, as a public health person, and as a researcher in these convoluted times. I would be delighted to hear your questions. I'm presenting from my phone, so it's not, the fastest thing to go see a question, but please feel free to stop at any point, and I'll do my best to try to talk to you in detail about any questions you may have. And the plan is to stop at about 45 after, so you have some time to address questions in more detail at the end as well. First of all, my next slide, please. Just wanted to say that as I've been an advisor or a part of one advisory board of the Peruvian government as of March, just wanted to say that these are just my opinions. They're not the official opinion in any way or form of the Ministry of Health, Peruvian government, or even the university. It's just a little bit of personal experiences and thoughts. The next one, please. I don't know how familiar you may be with how the pandemic affected Latin America, but we're the epicenter of the pandemic. We've been driving the pandemic forward. Not just the largest countries in the region like Brazil and Mexico, but also small countries like Peru have been very heavily affected. Officially, the first reported case of the pandemic was detected on March 6th of 2020. And the first death was originally what we thought was the first death was originally reported on March 18th. But soon after the data kept accumulating, surveillance came out, more surveillance came out, it was clear that it's probably been transmission before that, and some further reanalysis have added to this theory. So we think that probably the introduction took place somewhere around January. Peru had one of the fastest and strongest responses among Latin American countries compared to countries like Brazil. Still, at the highest level, the country is still grappling with the situation and acknowledging the magnitude of the pandemic despite the huge burden of deaths. And some other countries who didn't want to take immediate action and wanted to protect the economies. But Peru, actually, we closed schools really early after the first case. We went into national emergency, and had a very lengthy and difficult lockdown, like a full lockdown for 3.5 months, in the sense that, the extent of it was substantial, in the sense that children could not leave the homes for all that time. They just started to go out and walks, I think about 3 months after the lockdown, people started to go to selected to go to work selectively, for just some specific activities, not for many others. There's a curfew that is still ongoing. It was moved to 11 p.m. just a couple of days ago. Started on Monday, but it's been 9 p.m. or earlier curfew since March last year, and 24-hour curfew on Sundays that is still ongoing right now. For a time, people could only go out first for purchases one at a time, and with restrictions and with several attempts to make it more restrictive as much as possible to reduce chances of transmission. And there's been a number of additional periods of lockdown. For example, one of the last ones, it was for Easter, which is a big holiday here. The government shut down the country for 4 days, basically, in the middle of a very a complex election campaign. A very bold decision. So Peru has not been shy of taking such strong actions. The next one, please, to address the pandemic. Although the effect of that is still not completely clear. Peru, it's a low and middle income country with very limited resources, despite the fact that we've been growing annually in our GDP for a number of years. It's still a very, one of the lowest GDPs in Peru, and then in South America, and that and a limited and weak health system with multiple providers, decentralized and neglected for many years with very little investment. We historically had a very small number of ICU beds per 10,000 people, and we always lived at capacity with very few number of beds available, and always a challenge in public hospitals to find an ICU bed. So definitely when the pandemic hit, it really caught us unprepared in many ways. And to that, we had an unprecedented situation of political instability in the country that make it a lot worse to try to implement control measures. Next one, please. But among the several aspects of the response that the government established, one of the early actions that seemed like a good reaction, a good decision, was to establish a number of advisory boards in the first 60 days of the response. Among the number of changes that happened early in the response to the pandemic is that there was a change in the Minister of Health. Dr. Victor Zamora took office a few days after the emergency had been declared, that the lockdown had been established. And he decided to invite a number of people to join these advisory boards. And, I was among one of the people that was called and invited to be part of this group. There was a group called Prospectiva that was created, a bunch of epidemiologists, some mathematicians and clinicians and public health people. We were a total of 13 initially, invited to form a group to provide guidance to the government in the trends of the pandemic and potential these decisions or actions to be taken during that time. And you have me there in that photo with shorter hair. and a lot blacker hair at the time. Even 6 ministers of health were part of these boards and invitations. There's a lot of people trying to contribute with their experience. Next one, please. In that work, some of us as scientists had the opportunity and the challenge also to start to communicate with different audiences, not just people making policy, but also decision makers in the politics realm. People, sorry, I'm gonna move this here, news media, and sometimes dealing with the general public. And I'm a quantitative epidemiologist. I teach a lot. I communicate results, but to different audiences, not to many of those. So this was, for several of us, was relatively new. And there's the situation of, you can imagine, implied different levels of expectations and attention. There was a huge amount of attention to the topics, and the certain groups of the media, particularly social networks, have been incredibly active and proactive and aggressive in some realms, and they've been full of additional spokespeople, very mediatic experts that freshened the topic, became emerging diseases experts, and they became epidemiologists, and they came from all angles of professional experience, similar to what's happened in other places. Economists, programmers, data scientists who've never, set a foot in Ministry of Health office, with very limited understanding of the health system. Very smart people, very capable in their own fields, but they all participated actively in the discussion. So it definitely made a challenge to try to communicate complex ideas clearly in that scenario. Next one, please. So this has been a big effort of trying to understand what is the course of the pandemic, and what to do, what could be done, and provide guidance to the decisions of the Ministry of Health, that are technical decisions and some are political decisions. They are not all technical, and definitely the decision-making process is not completely technical. It has a high amount of political elements. And this in the situation of huge amount of uncertainty and very limited knowledge of what we were dealing with. The next one, please. So let's just skip this one, please. Let's just go to the next one. I'd like to talk a little bit of what data we've been using, because this is the structure closest to research-oriented or research scenario of our work. We, as good quantitative epidemiologists, several of us, when we joined this group, we thought that we were going to be given large databases updated daily, and be able to understand quickly the trends and generate new data and ask for additional information and be given that information. But we definitely face the challenges of a resource-limited Ministry of Health and working in this decentralized conditions of a semi-federal country. I mean, we're not a federal republic, but many aspects of government are decentralized. One of the best sources of data we found, it took us like a month and a half to understand how valuable this data was the death certificate system. That was a system that provided near real-time data on fatalities. And I don't know how familiar you are with your epidemiology subjects and concepts, but that's happened really late and describe the risk of an event that took place weeks before. So it's kind of a late indicator of trends, but however, the rest of the data was actually not even as good. So we found over time that the deaths were one of the best indicators, but even the most timely indicators of risk that we could obtain in real time to provide guidance for decision making. And it was independent of how many rapid tests or molecular tests or whatever tests were available in the country. That at the beginning there were so few, and it was reported from all over the country. Next one, please. So we also looked at every piece of data that crossed our eyes, but in many cases the data wasn't that great for different reasons. For example, occupancy of ICU beds and hospital beds was very biased because there were only ICU beds in the main parts of the country, main regions of the country. They were in limited supply, and once they get filled, they stay filled for a very long time. So they're not a great indicator. And hospitalization beds that are a little bit better, they're also a bias on how they use. When there's a lot of pressure, patients move much faster. When there's less demand for hospitalization beds, patients get to stay a little bit longer, and they're taken care with more detail and more attention. So hospital stays lengthen, and they don't really reflect risk in any way. So we thought about going one step before, as many have done, looking at the results of testing to see whether the proportion of positive tests of molecular tests or antigen tests more recently can tell us how the risk is evolving. And we run into the issues of molecular tests not being available enough, taking days to weeks time to be available because tests needed to be moved from one location where they were taken to another location when they were actually processed. And they were only in main cities, and antigen tests really came late in the game. They started to be used heavily in January, starting in January. And there was no background rates, and they're still in limited supply, and the supply number has been changing over time. So at the beginning, they were heavily used only in the most clinically evident cases, and later they were just applied more in general to anybody suspected. So the target population was a moving target permanently. And then if you go to positive cases, it wasn't really reliable data, because as tests, and originally molecular tests were one of the early tests used, they were so unavailable that the cases were coming from rapid antibody tests that have very low sensitivity early in the course of disease, and then they become positive for weeks or months. So the number of cases was at the beginning lagging behind really far because of the use of antibody and molecular tests. Just recently it's getting better, but also depends on how many tests you use and how quickly you get results. So it's been difficult to get very good data, and not all the data was necessarily available on real time, or available at a friendly hand that would allow it to allow these advisory groups to have the data at all times every day for weeks or months or over a year. So it's been challenging to have access to the best data available. So we stuck with mortality data, and the government made it public, put the database daily. Until now, it's available daily. They made a big effort for transparency that we applaud. So that we used that, given that it was delayed, but reliable data, we used it for most of our, for a big fraction of our analysis. Next one, please. And yeah, next one, please. I duplicated this. So here is just as an example, so you can get an idea of what we've been doing. it's been fairly basic efforts, mostly with geographic and time disaggregation to understand trends, to know what's going on right now and what may come later. So imagine yourselves navigating in every part of these curves. I mean, we were at the beginning when we joined the Ministry of Health, and the curve was really at the bottom, starting to go up, and we were telling at the moment the ministry, it's starting to accelerate really fast. You have very few deaths right now, but the acceleration, the pace that is moving up is really high. And it's mostly in Lima, we're in lockdown, but it's probably in other places. And then we saw that vertical, that exponential phase that has been described by many. And it was a hellish period in which our expectations for increase in the first wave were always exceeded by the pace of the pandemic, until at some point somewhere around May we started to see that the curve was the epidemic curve was bending a little bit, was showing what some in our mathematical analysis we said, the speed is reducing. The second derivative is about to reach zero. We're about to, at some point in the next weeks or months, we're going to reach a peak, but it's starting to change the speed. And then, every single step of it, we managed to provide some more cautious and sometimes a little bit more, how do I say, audacious, sometimes not as cautious advice on what would happen later. And sometimes we got it and sometimes we didn't, because who knows about this pathogen. So then the curve started to drop really fast at the end of the first wave, sometime around August, September last year. And it went down, and at the time we didn't know much about variants and the mutations that were activated, that were enabling higher level of transmissions of the virus. And then the variants so they were circulating, plus Christmas, got us really bad. And in that case, we didn't know what was going to happen. When we started to see the increase of the second wave, we could tell, based on what we had learned from the first wave, what we see elsewhere, we could tell really clearly that Christmas was going to make a really terrible second wave, and the actions were not strong enough at that time. It was a very different context. It was a very complex situation, and the curve just went up. And it's now coming down, as you can see. And we're starting to have good weeks in which the whole country almost comes down, but there are still challenges. And next one, please. And this is, I'm presenting you what is the weekly report, but there's daily analysis with summaries sent on text to a number of decision makers, and with specific suggestions on what could be done or what could be watched or monitored more in detail, because as an advisory group, we just had partial information at hand. We didn't have all the information at hand. So we also, here we're looking at the trends of ICU and hospitalization bed occupancy, and now how it's coming down really quick. And it's a hopeful scenario, but at the same time, we starting to see new variants appearing now that we have molecular surveillance, and those some of those trends appear together with the next one, please, with changes in the curves. And this is just one other of our panels showing where in the country, there rises, and what level of rises. And you can see the up in the fourth row from the top, the Arequipa region in the south has this lengthy yellow line that basically means that this region has been increasing the number of fatalities week by week for 6 weeks, breaking their previous second wave records. So it's been growing out of control for 6 week breaking records. And before that, it's been growing 4 weeks as well. So it's been growing for quite a long time. And, during that process, the government has confirmed the presence of the Delta variant in the South. And apparently this is a big risk and extending to the rest of the country. So we, in many cases, these trends have matched other important findings, and in some cases have led to important discussions with ministers and with vice ministers, or sometimes with the president and with the first minister as well. But in other cases, it's been a frustrating situation in which, the suggestions that we provided were potentially too extreme or not politically viable and not being able to turn into policy. The next one, please. And the geographic analysis of different regions. I mean, the names of regions may not mean much to you all, but these are all the regions in the center of the country, and regions that are contiguous to one to the other don't necessarily follow the same trend. And there's also, that shows a good amount of heterogeneity in space, but also heterogeneity among indicators. So you follow mortality, you follow a bed occupancy, you follow test positivity, and they all tell you different the situation of different moments of the pandemic. And together you need to come out with a single image of what is going on right now based on this, what's going to happen later, and what can be done. And not just for the whole country, because the country is basically just the conglomeration of our 25 regional pandemics separately of each department of the country. But you need to provide a global image and global actions countrywide, and also suggestions at the regional level for individual actors. So when we talk to the epidemiologists of the Cusco region, or when we're talking to the to a decision maker in the north coast or in the jungle, so they can make their own independent decisions. And the next one, please. And this heterogeneity can be seen very clearly when you look at in the left, for example, the curves of the different regions. How right now, for example, you see that yellow curve in the left graph that is starting to come down. That's the southern part of the country where the Delta variant is circulating right now. Now that is finally starting to come down, hopefully. It may be the second week that is going to come down, but it's been growing out of control while the rest of the country was coming down. And that has been the scenario also in the first wave, that every region moved on their own speed based on their own characteristics and connectivity with the rest of the country. And it's even worse when you look at the graph on the right-hand side. When you look at each one of the 26 regions of the country, each of them may be working separately and has their own individual experience in the pandemic. So that has been the job, like looking at this data, trying to come up with hypotheses and about what may happen, guesses, and provide potential suggestions, and that were, but that have to be tested by decision makers to see if they're viable to be implemented. And we analyzed a lot of these trends, but we also kept analyzing evidence also about other things to do. Peruvian government was very aggressive early in the adoption of masks. So the whole country mask stopped in mid-March, when we went into lockdown. The mask mandate came out that if you, for any reason, needed to go out, you need to be in a mask. And that was really early. That was way before WHO and the CDC endorsed the use of masks. But Peru did on its own, was heavily challenged by many. It was a bold decision, it was a right decision. And just like that, we kept being asked as a group also, what are your thoughts on this and that? What do you think about the evidence of this and that situation? You know, the second wave, the possibility of a second wave, the chances of variants, many, many questions. And we were also revising evidence and to try to address those questions in addition to our regular work on analyzing trends. Next one, please. The government at the same time conducted several seroprevalence studies that showed the extent of the pandemic in horrifying levels. So, you know, seroprevalences of antibodies up to 70% in some parts of the country, and very high in general in most parts of the country. Next one, please. And also very large, substantial gradients of risk, showing how people with sufficient resources and income can protect themselves and remain at very low levels of exposure, while people with low socioeconomic strata did not have that capacity, and where, you know, half of those people were potentially infected or more. And those disparities make it very difficult to control a pandemic in this scenario, in a scenario of a country like Peru. The next one, please. And the background of the political situation of the country did not help at all. And you may have seen some of these in the news. I'm not sure the news can capture really not just the complexity, but the severity of what the country has lived. We can go to the next one, please. This is about the period of 6 days where we had 2 presidents. Or if you extend it to 7, the period where we have, or 7 or 8 days where we had 3 presidents, where, you know, one president was ousted on charges of corruption. It was constitutionally legal process, but done on only political basis at the moment. They did show, it is clear now that the president was corrupt indeed, but at the moment, the charges that were used were inappropriate, and definitely had a huge impact on the actions that were taking for the control of the pandemic. We were at the Ministry of Health at a time, and during those 8 days that we had 3 presidents, we had 3 ministers of health. And the first one had to leave, the next one entered and wandered around the hallways, had a few meetings, started to plan work, and then had to leave again. And then the old minister came back. And that basically implied 3 to 4 weeks of a lot of interruption. And health was the only minister, the minister of health was the only person, the only member of cabinet came back. There were 2 actually. I think it was, the other one was culture. But only 2 of the ministers came back. Everybody else, every other minister had to be replaced, with all the impact on the economy and many other things. And that was just the aspect of the presidency and the ministers. The next one, please. What that just describes is a situation of permanent instability that we've been living in Peru, and it got worse in the last years, but definitely is part of the normality here. That since, you know, the 30s, the average length of stay of length of mandate of a minister is less than a year, and it's been minister have been as short as a period as 1 day. And in their life since 2016, this became even worse. And during the pandemic, there've been, in my recall, 6 ministers of health. One that took it, that was in office when the pandemic started. Then she was changed. Then Victor Zamora came in March last year. He was replaced in July. Dr. Amasetti came in as minister in July. In November, she was ousted with the president. The 6-day minister came, and then he was replaced again with Dr. Massetti, and she left in February again. So in less than a year during the pandemic, we had 6 different ministers, and in some of those cases, the people who were working with those ministers remained, like the vice minister, the director generals, the executive directors of different offices. In many cases, all of those people were replaced, because they're trust positions, trust-based positions, and it implies a huge delay on everything, and that everything in this case is acquisition of vaccines and many other life and death type of processes. Next one, please. And the last element of this crisis, and at least in the health aspect, is the vaccine gate. The event related to the Sinopharm vaccine trial that was being conducted here, in which the investigators had arranged, and with the approval of both governments of Peru and China, for a number of doses of the vaccine still in a trial situation, to come to be provided to the study personnel, but with an additional clause that it could be provided to the study personnel and additional support personnel. And that condition of additional support personnel was, I'm missing that slide. I'm sorry. Can you go to the next one, please? No, I'm missing that slide. The next, the one before, 2 before, please. Oh, that's really too bad. I missed it. Yeah, I missed the vaccine. I'm so sorry. This is that's a slide that is that has a very personal importance for me, because I'm part of the study personnel of that trial. I was vaccinated with 2 doses of an experimental vaccine because the trial had a clause for that, and that trial protocol was approved by the national regulators. But those doses also served to vaccinate the president, who did it in private, and he did lie to the country about it, and then he was ousted because of that immunization situation. So sorry that the slide is not there. And this became the next political crisis in February 2021. This led to Minister Massetti being also replaced, and the Minister of Foreign Affairs also being replaced, because they both had vaccinated as well. And they were considered that there were irregular immunizations because they were not part of the trial. They were not they were not study personnel of the trial. But this was also a huge political scandal, because at that moment, President Vizcarra, no longer president, ex-President Vizcarra, he was running for office in Congress. And he was extremely popular, and he became the most voted Congress candidate in this election, and he was elected. But Congress managed to get him out and prevent him from taking office, and have him banned for 10 years because of his immunization and the way he lied to the country about it. So it was a terrible crisis for the country. The fact that so many people had been vaccinated with an experimental drug, experimental vaccine or product that was not tested, but it was approved under a process. The slide actually that I wanted to show you there was a response of the university saying that there were some regulatory oversight issues with the trial, because the trial had been approved for the use of those doses for the study personnel, definitely not for presidents or ministers. but for study personnel. But it's been a major challenge to the confidence at the moment in vaccines, the confidence in science, the confidence in several academic institutions like the one I belong to. And personally, for me, it's been a major event. It's been a situation that has prevented me from continuing with my career as a faculty, as an investigator. I had to interrupt many activities. The investigations are still ongoing. Hopefully they will be solved soon, but still since February, there's no final decisions on this. So it's still ongoing. And sorry, again, the next one up now. And that leads us to the last topic that happened in April of this year, when in May this year, I'm sorry, when the government decided to involve yet another work group of experts to revise the estimates of the number of deaths due to the pandemic. And this group of experts, some of them experts and some of them very prominent members of social media, decided that they would opt for an alternative definition of COVID-related fatalities, in which they were no longer required to have a COVID test as confirmation of COVID death, as most definitions in the world have used. So naturally, the number of deaths in Peru has increased tremendously. It doesn't really deviate much from the figures that we had been using in the past, but it definitely increased the official tally of fatalities by a large margin, and caused waves of global concern, given the growth of the rates. Although the government had been saying since May last year that definitely number of deaths is much higher, and we will exactly not be able to say how many, because it's very difficult to pinpoint the cause of deaths and to have enough tests for every case, and many of them just died without laboratory specimens. So this was actually something that was known, that all countries cannot count or tally all the fatalities, but this became big news because of that abrupt change in the definition. And despite the fact that the country had already placed the data publicly for everybody to be able to see it if you would want to, this was considered news. This was considered something new and different. So just to summarize a little bit of the ideas, the next one, please. Epidemiologically, what we faced was a very heterogeneous and complex epidemiology of an emerging disease, with a significant burden in the country, definitely well reflected by the fatalities captured in by the SINADEF system with the death certificates. But the amount of disparities and the connectivity between regions being a major factor for the spread that we've seen in the past and now. And given the frailty of our system, it's been a major challenge for Peru. Next one, please. The most important part, because epidemiology, go to UCLA and learn very good epidemiology, but a life lesson for me is very critical to be able to understand the many perspectives that there are about this type of events. And, political, the social media, the population, there's so many different angles, always conflicting, and you may disagree with them, but you need to take them into account. And, as you're training in public health or epidemiology, and you get that opportunity to take a media training session, just take it. It will be valuable at some point in your career, very valuable. And build long-term bridges, because these temporary setbacks and in particular situations, you know, they pass, they eventually go away, and what you build in your career stays on, regardless of what the day may be, how bad the day may be. And the American Society of Tropical Medicine and Hygiene, that, you know, I've been part of for a number of years. They said it a number of years ago, there will be epidemics. This is one, there will be others. So this is just something we learn in preparation for the next one. So with that, I'll stop. Thank you very much again. If we can go to the next one, my contact information is there. Very happy to talk to you in more detail through the questions to get into more detail with this topic. I hope the presentation was sufficiently well organized, and I'm really sorry about that, that missing slide about the vaccine gate in Peru. I'll make sure to send it again.
Great, thank you so much. So we still have about 10 minutes if anyone has questions or comments about Dr. Lescano's presentation. That was such an amazing overview of the situation in Peru.
I never thought my health policy masters would be so valuable. And at the same time, I never felt so underprepared.
My name's Tucker. Thank you so much for that talk. I'm one of the medical students in the group. It was really interesting to hear about some of the political backdrop as well, because obviously things were very politicized here as well, much different, but still just the way that policy and politics plays in. I'm curious of kind of the disparities within Peru. Obviously there was a lot of marginalized folks here that were hit a lot harder with COVID because of structural determinants of health, because of being frontline workers and family structures and structural racism. So I'm wondering the way that that played out in Peru across different populations and kind of the structures that were in play to create those disparities, if they exist.
No, Tucker, thank you very much for your question. Those social disparities are definitely huge, and it's definitely socioeconomic strata. It's also class related, and there is definitely racism and discrimination. But I think the primary factor there is socioeconomics, is the ability to stay in social isolation, and your ability to provide yourself from masks, from ventilation, from access to open air, to later the access to a hospital bed, to an ICU bed, to now vaccines by vaccine tourism, and now revaccination. Go back to the US for another dose if you feel like your 2 doses of Pfizer are not going to protect you enough. So I think a lot of that is driven by socioeconomics. Then class adds to it, and there's an important element of it. But I think the primary one is socioeconomics, and race and class come a little bit forward. We're a mestizo country. We're all, in large, many of us are in large fraction Amerindians. So I don't think that's such a major factor overall.
Thank you for clarifying that. I actually have one more question kind of on that, about that I may have missed, but about like vaccine, less access to vaccine and more like the vaccine hesitancy. There's a lot of vaccine hesitancy in the United States with different groups for different reasons. Part is political and part is abuse by the medical system in certain populations. And so I'm wondering what that looks like, uptake and just kind of the response to folks getting the vaccine in Peru.
Yeah, one of the biggest factors for vaccine skepticism here was the vaccine gate scandal and the how that weakened the trust in Sinopharm and what everybody calls here the Chinese vaccine. That was because of the trial and because it was the first one that was negotiated and arrived to Peru. So the government had to fight a lot to rebuild that trust. And there's a fraction of the population who's still not developed it. And that event also affected the ability of the country to negotiate more doses with Sinopharm. But luckily, the government had also been working both with COVAX facility as well with Pfizer. And now we have a very large amount of Pfizer doses coming at the beginning from COVAX and now through direct negotiations of the country that are reaching people under 60 right now. So the government was able to rebuild, and the scientific community came back and supported the decisions. But the political battle between some presidential hopefuls was really big, and it has been a factor until as recently as in March, when the vaccination expanded, and we don't have the background of vaccine hesitancy that Europe and the United States particularly has. We are a country that has just very recently extended our life expectancy because of vaccines. So they're still fairly well accepted, and anti-vaxxers are just growing among higher SES groups, socioeconomic level, but it's still a small fraction only. So we were lucky that it had not, expanded as much as it did in many parts of the US, especially in California, actually, for what I know. So no, we were lucky in that way. We were able to rebuild. There's terrific questions, Tucker. Thank you.
Yeah, thank you for expanding on those.
Great. Any last questions or comments?
I'm happy to ask a question if other folks don't have. It's nice to meet you. I'm faculty in public health in health policy and management. So it's lovely to hear the emphasis on policy and politics. I'm often very interested in financing for health, and financing the COVID response in middle income countries has been somewhere between challenging and controversial in a lot of cases. And I'd love to hear you sort of talk a little bit about, particularly since you just mentioned, transitioning from COVAX to negotiating directly with manufacturers. Can you just talk a little bit about the politics of financing and sort of how that's playing into decisions that are being made in Peru?
Yeah, no, it's fascinating, and that's an area that I haven't had that much exposure to in the past. But I remember when President Sagasti came in November, and he appointed a new Minister of Health that was well known for being conservative in spending. And at that moment, at the beginning, the emphasis was on whether we opened the economy, given that we were in a lowest point of our curve, and or we restricted to prevent a second wave. And there was a lot of discussion about that. But one of the biggest reassurances that at the moment was meeting with the president, the prime minister, and the minister of economy. And the Minister of Economy had just had clashes with the Minister of Health because of their position on opening the economy. But in vaccine expenses, they were looking right each other at the eye. They were like, vaccines are the best investment for the economy of Peru. We're gonna buy as much as we can in excess, pay more if we need to, but this is the only way out for the country. And now we have what has been suggested, I think, a supply of 60 million doses of vaccine for 33 million people in the country. We could vaccinate children, below 2 years old, but at the end of the year, when vaccines arrive, the effort has been fantastic. And not just the lowest efficacy, most available vaccine. This is Pfizer. And coming out at 500,000 per week. It's been terrific. And you know, I don't no longer work with them. I don't no longer work for government, but I have a huge amount of respect for the vision of the leaders of Peru, who in the right moment decided on not just vaccines recently, but also masks at the moment and the lockdown. I can't imagine what would have been without a lockdown. It didn't stop the pandemic, but who has stopped the pandemic? I mean, so there were very bold decisions taken in very uncertain scenarios in investing the economy. And the previous minister of economy, Tony Alva, a very young, one of the youngest public servants to be ministers, at 33 years old, an amazing woman, trained in Harvard at the master's level. And what she was told by her professors from Harvard is get ready for a 2-digit hit on the GNP and just take it. It's fine. You will bounce back. But you'd rather have your economy hit that the population hit. And still with that, we were hit really badly. So I think people tried their best. It was just that the country was unprepared. We had nothing. We have a very limited infrastructure. The growth of the GNP doesn't really reflect on what the country has. It's just temporary growth. You can grow for 10 years, but still have one of the lowest GNPs of South America and still be very weak as a country. But the financing question is amazing. It's not an area of policy that I've been involved in. I don't know it enough, but I think good decisions have been made. Not all, but very good decisions have been made over time.
Thanks.
Well, thank you so much, Willy. This has been amazing. We really appreciate your time, and we'll send your slides and the recording of this talk around later today. So thank you again, and we're right at the hour, so we'll let everyone run. Have a great rest of your week, everyone.
Thank you.
Thanks so much.
Thank you so much, Willy. Thank you.
Bye.
Bye-bye. Take care, you guys.